Hi, I'm Dr. Robert Glatter, advisor for Medscape Emergency Medicine. More than 20,000 pediatric cardiac arrests occur annually in the US, but the outcome for about 7,000 annual pediatric out-of-hospital cardiac arrests have remained poor, with no significant improvement for decades in overall survival and neurologically intact survival. To address this ongoing issue, the 2020 PALS Guidelines Committee made some changes. But the issue with the changes is whether the evidence truly supports this change in practice suggested by these guidelines. So here to join me today to discuss this are two seasoned EMS physicians. The first is Dr. Peter Antevi, a pediatric emergency physician at Joe DiMaggio Children's Hospital in South Florida and medical director for Coral Springs Fire Department, Davie Fire Rescue in Palm Beach County. Also joining me today is Dr. Paul Pepe, professor at UT Health Science Center in Houston. Welcome, gentlemen. It's really great to have you with us today.
Thanks, Rob. Great to be here.
Absolutely. And Peter, I'm going to start with you. The impetus for this discussion came from your suggestion that these guidelines need to be discussed, basically because a lot of people may be unaware of these changes that kind of slipped in the 2020 guidelines. And with COVID obviously on everyone's mind, this may have been an issue which may have led to these changes being overlooked. And I'll let you dive right in and talk about these changes, since you were the one that really brought this out in the publication in the Resident Eagle and EMS world.
Yeah, thanks, Rob. I appreciate it. Yeah, the guidelines that came out in October of 2020, published in circulation, of course, it was right in the middle of COVID. The concern from not just myself, but for many in pediatrics, is that they went from 10 breaths per minute, or 1 breath every 6 seconds for cardiac arrest, and that was for all ages. They then said, let's change that for the pediatric population to 20 to 30 breaths per minute, doubling and tripling the ventilatory rate in cardiac arrest for kids. And the level of that recommendation was a 2B, and it was a level C LD, or limited data. And when you see that, the first thing you do is you go look at the actual paper that made that change. And when you look at that paper, it was an observational study, only 47 children in that study, and it was done from a collection of ICUs. It was a network of ICUs doing this paper. When you look at those patients in that study, of only 47 kids, and by the way, it took them 3 years to accrue those patients, you see that 60% of them had pre-existing congenital heart disease, number one. Then all of them were intubated. All of them had arterial lines. And then most concerning was the presenting rhythm. Now in EMS, and Dr. Pepe will tell you this, that we mainly see asystole PEA in the field. In this particular study of 47 kids in the ICU, 74% of them presented with bradycardia with poor perfusion. And so when you looked at the children with asystole in that 47 children study, all of those patients died. So to take an observational paper with small numbers that ended in 2016, didn't publish till 2019, you start to say to yourself, is this the same population that we are treating in the field? And I think it's a resounding no. And to that point, and I'll stop after this point, when you look at the same guidelines, the actual publication in circulation in October, ILCOR publishes their recommendations, and they in fact stayed with 10 breaths per minute. And they said, not enough data. This is not good enough to have a single paper that's an observational trial. So I'll throw it back to you, but that's really the issue for me. And I think people should really look at that study before they make a change.
Absolutely. So Paul, what do you think about this? One paper just making a guideline change off that really seems kind of odd.
But I think Peter hit it right on the head, that the child in cardiac arrest out of hospital is a whole different species, so to speak, in the sense, several things. One, they're dehydrated, so therefore they have a very poor preload. Theoretically, in the ICU, they're being cared for under those situations, but most of our patients aren't. Two, they're behind the 8 ball in the sense that there usually is a respiratory component that does it, and then they get hypoxemic, and then they brady systolic down into nothing. So by the time we get there, when they have a cardiac arrest, they're far behind, just as opposed to like our VF patients who are still fully oxygenated when they went down. Now we're dealing with a different creature that needs immediate care. And so, and then also the issue is that the ventilatory thing, that's a whole different animal, because ventilation has to match perfusion. You have a low perfusion state. Yes, it might have been respiratory before, but it's cardiac arrest now. And so the concept of just simply giving a lot of breaths is confusing. That's like saying doing really good CPR, but not going deep enough or going too fast. You have to have a lot of components. It's how fast do you deliver the breath, how large a breath do you deliver, and how often you deliver it, especially since they're positive pressure breaths. And I'll go into more detail with you later if you like to understand the physiology. But in my settings where we've come in and done things, we've improved outcomes dramatically when we control ventilation in multifaceted way, and it doesn't involve going fast.
Right. So it's an issue of oxygenation at the expense of flow. If we increase oxygenation, can we also increase flow at the same time? Is that possible? So I guess that's what we're trying to balance.
Well, the answer is yes. And one of the interesting things I think people don't appreciate is that, what you want to do is, one, recruit as many lung zones as possible, right? So you do that. So we like to emphasize that there should be a large breath. You can't really totally measure it, but if you get a good chest wall rise, for example, in a child, maybe 1 or 2 breaths, but you get that. And there's a secondary agenda. Not only are you recruiting every lung zone you can get to oxygenate, but you got to move blood through there. If you're doing CPR and compressing the chest and you start getting atelectasis, you're closing off airways, and therefore you can't get blood flow through it if it gets atelectatic. So you've got to make sure that all the lung zones stayed open so we can get blood flow. We've shown in the laboratory in smaller, animal models, so to speak, that are closer to kids, that you do get increased pulmonary vascular resistance, less blood flow for the CPR when you don't have a good lung inflation. But by the same token, you give a good lung inflation, that's fine. Then you have that positive pressure there. But if you don't give it, what we've normally done is not give a breath for every 10 seconds in children. And that made sure that we kept the intrathoracic pressure pretty low. And it's been phenomenal what we did when we got right to the kid, gave the drug right away, gave a large breath, and only did it very rarely. And we improved outcomes dramatically in the places we've gone into recently. And Peter could tell you a little bit more about that instead of me talking about what we did. But what I'm going to say is that it's multifaceted. It's not just the rate, it's not just the depth, it's how you do it, when you do it, and under what circumstances. Now, given that children have different metabolism, they have different needs, but when you're in a low flow state and you're dehydrated, positive pressure ventilation is going to knock it out. It's a different species, so to speak, as I said.
Right. And so, Peter, I'll let you weigh in on Paul's comments.
And I think everything Paul's saying is right on the money, but and what he's pointing to is this flow that you mentioned as well. And so when you look at the 2 main organs that we're trying to save, which is the brain and the heart, both of those are interconnected very deeply with the lungs. And if you're increasing that intrathoracic pressure to the point where you're squeezing down the heart, you're not letting the RV fill, you're essentially killing the cardiac output. But then secondarily, you're not allowing the blood from the brain to drain into the heart. And when you look at Keith Lurie and Tom Aufderheide's paper, that actually helped us understand this physiologic issue. They actually looked at pigs, and they had a group of pigs that they breathed at 12 times a minute. These are pigs that they put into cardiac arrest. Then they had a group of pigs that they breathed at 30 times a minute. And it was a dramatic change, not only in the cerebral perfusion pressure, the slower you ventilate, the better the perfusion of the brain, but also they only had 1 pig survive in the 30 breaths per minute group, and they had 6 pigs survive in the 12 breaths per minute group. So everything Dr. Pepe just said, I think that makes us understand that it's all about flow, and using the bag, thinking you're affecting just an entitle or an SpO2 is really short-sighted. And I think really that's where this discussion should be happening, is all about the flow.
Right. So why is the committee now, what's biasing them toward this change? This is to make a change in the guidelines means that there's evidence that supports, an increased outcome or a clinical outcome that would necessitate this change. So we're not necessarily going to, we don't have data for this, and that's my complaint.
Right. And so I'll tell you just a little bit of history here that's important. In 2015, PALS made a recommendation, and they used the term for fluids, for kids in shock, right? They said it's reasonable to give fluids, but be careful. And why did they do that? Because of a study in 2011 by Dr. Maitland, where she studied kids with malaria in sub-Saharan Africa, where there was no ventilator and no ICU, and found that those children who got fluid boluses happened to do worse. So what did the guidelines do? They then brought it to the US and they scared everybody from giving IV fluids. Now, 5 years later in 2020, they said, we think it's time to revisit that recommendation. So they have a history of doing it. Here they've done it again. My fear is that people who aren't reading the papers and aren't digging into the guidelines are just going to go and start 20 to 30 times a minute. Now they've had to come back and clarify, and they said, oh, by the way, the 20 and 30 times a minute only means an advanced airway, which it says in the guidelines, but then they said, oh, we meant intubation. In EMS, we typically BVM or we throw a supraglottic airway in, right, mainly. Mm-hmm. But now there's all this confusion that you start with one rate, you finish with another rate if you're intubated. I personally think, Dr. Glatter, that because, as Paul mentioned earlier, out of hospital and in hospital cardiac arrest are really two different animals, that we should probably be thinking of them separately and perhaps have two sets of guidelines that distinguish between the two.
The other thing is that my theme is that always is that ventilation needs to match perfusion, and there's other factors that go in there. So if you're at a low flow state, you don't need a lot of ventilation because there's no flow going out there, there's no flow going back to the lungs, et cetera. And so it all changes. And once you get pulses back, then it changes. It is all a dynamic. And there's also other things going on. But what I'm saying is that we have thought too much about this or that. It's a binary mechanism. And it's just like CPR quality. You have to have an accurate, right in the sweeter spot of the right depth and rate and good recoil. The same thing for ventilation. You have to have the right depth and rate depending on where you are, or whatever device you're using at the same time. And that CPR affects ventilation affects CPR. So all those things have been got to put together in a bundle. And as you know, in the resuscitation study in 2019 by Banerjee, he bundled all that stuff together really well, documented what he was doing. And they were able to take like 10 years of zero survival, neurologically intact. They got 5% resuscitated of the kids, neurologically intact, and then jumped it up to like 30 or 40% over 2 years. And even though it's a historical control, I mean, he had no survivors, and all of a sudden he's getting back, 40% neurologically intact by doing quality CPR, getting an IO in the right place in right away, by at the same time simultaneously getting, IGL or intubation right away, and controlling the rate meticulously with a good large breath, and then giving it less often, like once every 10 seconds. Think about that, just the opposite, what we're talking about here. And then also made sure that there was hydration, and all those things were all bundled together, and they did tremendously better. So there are data out there to support a different a way of approaching it. And so I hope that helps in terms of understanding.
Yeah. My question to you, Dr. Pepe, is what is the value of this initial breath, and what role does it play in the outcome of the resuscitation? This large breath that we talk about, Peter talks about, at the initial onset of resuscitation. Yeah. If it's not adequate, does that predict outcome?
Well, again, I don't, I can't tell you if it's the ventilation that made the difference in the kid's outcome, if it was the CPR. It's really all those things together because they affect each other. They're interrelated. That's the theme here, okay? The big breath is all I said was, as I started early on, is that you've got it. We've shown in the laboratory very well, good models, that if you get a good lung inflation, you diminish the pulmonary vascular resistance that rises as you get atelectatic lungs, that you keep things in an inflated state. But you can't give the breaths that often because you give too much inthoracic pressure, especially if you're dehydrated and you get no preload in, well, then you got a problem. So all it is that it's not the initial one. It's just that when we give it breath, we make sure it's a good lung inflation, and then just give it less open. The trade-off on the intrathoracic pressure is well worth it because you get better flow through the lungs. So no one even thinks about how the lungs affect the blood flow, and that's part of it here too as well.
Right, absolutely. And Peter, would you want to add it to anything?
Yeah, no, I think that the study that Dr. Pepe just alluded to, the Banerjee study in Polk County, that they actually went the other way. They have 6 breaths per minute. They have the bundle, right? They stay on scene, they do all the right things. And they have so many more kids who are neurologically intact. And when I wrote the op-ed to the AHA and I said, hey, what about that study? Then of course it wasn't a study for them that really isolated ventilation individually. And so, you know, we all know, and there's a lot of papers out there that look at one particular thing. Just like back in the days, they said that the ITD didn't work. Well, it did work when you looked at actually CPR that was being done at a high quality level, and you were in the sweet spot, if you will. So it's hard and it's wrong to take a study, nonetheless a 47 patient observational study, and look at one thing that was done differently. And basically that study where they went up to 20 and 30 times a minute, that wasn't the initial intent of the study. They kind of found that by happenstance, and then they're now attributing success because of that increased ventilation rate. So there's a lot of things wrong with how we're interpreting the science, and I think everyone should be realizing that when they look at this.
Absolutely. I want to also move on to the second change that got buried a little bit in the guidelines, talking about cardiac arrest, dose epi for Brady with poor perfusion. And certainly it's not recommended in ACLS, as you allude to, but it's still around in the pediatric guidelines. And you bring up a point about Dr. Holmberg's paper in April 2020 that's published in Resuscitation about epi in children receiving CPR for Brady with poor perfusion. I'll let you get into that because I think we need to discuss that issue as well.
Oh yeah, I mean, listen, anyone who's in emergency medicine or EMS knows that if I take an 18 gauge and I put it in your right AC and I give you a milligram of epi, a cardiac arrest dose for an adult, we would all end up in the cath lab, every one of us. To think that in children, for some odd reason, giving them a cardiac arrest dose when they still have a pulse is going to be any different or less harmful is short-sighted. And so this paper that came out in 2019 by Holmberg, as you mentioned, had almost 7,000 patients in it, not 47, but almost 7,000. And when you look at the risk ratio plot, and you can see that a majority of these kids would have benefited without getting epinephrine. And the conclusion was made very firmly that cardiac arrest epinephrine for symptomatic bradycardia is harmful. And the guidelines actually speak about this paper, even though they said, we saw the paper, we didn't make the change. And what we would recommend is some push pressor epi or an epi drip, just like we would do if it was an ACLS patient. So I'm one of these pediatric people who doesn't feel that we should be treating kids differently when it comes to, these, advanced life support items. And I went and I changed my protocol in 2019 based on this paper. I've seen too many kids in my own practice who were, let's say, just vagueling in my emergency department, and I see physicians coming and squirting them a cardiac arrest dose of epinephrine, and the evidence just doesn't bear it out. And here we are again, now having to wait to another guideline for them to want more data. So there's inconsistency in how they're picking and choosing which articles they're using to make these changes in the guidelines. And
Paul, would you agree with Peter's thoughts on this?
Yeah, so if you have, again, if it's a child who's perfusing and been there in a state with, who's been okay, yeah, you don't have to jump to it there. And again, keep that different from a cardiac arrest, because in cardiac arrest, the reason why it's been useful, like say the kids who have now been in hypoxic for a while, they're having peripheral vascular relaxation, there's no more vascular tone, and the quality of the CPR is not that good because you've got a wide open pipes. So that's a whole different circumstance versus a child that's been perfusing fine for in the prior minutes, that kind of thing. So I think that's why.
Yeah, and Rob, I'll say one more thing that when you're trying to resuscitate a child and you're trying to feel for a pulse, right, during your resuscitation to see if you have anything, and let's say you have PEA on the monitor. What a lot of people don't do is they don't look at the end tidal, right? And we know if you have a jump in your end tidal from, let's say, 5 to 35, you still can't feel a pulse. Unfortunately, many people will still go ahead and give that child another dose of cardiac arrest dose epinephrine, when in reality, what we should be doing is using push pressor.
Yeah.
And so a lot of those kids who you may have been able to resuscitate are now getting a medication that's putting them back into cardiac arrest. So epinephrine, like Paul just mentioned, is a dangerous drug when not used correctly. And the only reason it works in cardiac arrest is to push up the diastolic pressure just a little bit so we can perfuse the coronaries just a little bit more. So
but
you
your
have to
approach,
use that drug the right way.
but your approach, Peter, is better because one that we often see is that when we do give epinephrine, you get this pulse, and then you say, "Oh, we got a great pulse back," and then all of a sudden, boom, it falls off, and you have to play catch up. Whereas your approach, where you steady state it in, is much better.
And then I'll take it one step further, Rob. I'll end with this: is that now in Broward County, what we're doing is we're not using cardiac arrest dose epi for adult and pediatric arrest. We're using an intra-arrest drip. That's been done very successfully in other places around the country with great success. And so I think that this 1 milligram in the adult every 3 to 5 minutes is a lot, just like it would be the 0.01 per kilo in kids is probably too much.
Absolutely. I think this discussion really highlights some important points that people really need to take away. And I want to thank both of you for taking the time to join us. This really has been quite informative. Thanks again.